Updated NICE guideline on fetal monitoring in labor. Information and supported decision-making. Discuss fetal monitoring options with a woman as part of her antenatal care and document the discussions and decisions in her personalized care plan. Throughout labor, provide women with information on the fetal monitoring method being advised and the reasons for this advice. Support the woman's decision about fetal monitoring during labor. Include birthing companions in these discussions if appropriate, and if that is what the woman wants. Document these discussions and decisions in the woman's notes. Keep women and their birthing companions informed about what is happening if additional advice or review is being sought by the care team, for example from a senior midwife or obstetrician. Assessment during labor and methods for fetal monitoring. General principles. Perform and document a systematic assessment of the condition of the woman and unborn baby every hour, or more frequently if there are concerns. Discuss the results of each hourly assessment with the woman and base recommendations about care in labor on her preferences and her reports of the frequency, length, and strength of her contractions, or any antenatal and intrapartum risk factors for fetal compromise. The current well-being of the woman and unborn baby. How labor is progressing. Include birthing companions in these discussions if appropriate, and if that is what the woman wants. Remember that a fetal heart rate monitoring is a tool to provide guidance on fetal condition and not a standalone diagnostic tool. The findings from monitoring need to be looked at together with the developing clinical picture for both woman and baby. Ensure one-to-one support is maintained by having a midwife remain with the woman throughout labor. If the midwife needs to leave the room or there needs to be a change in staff, ensure the woman knows this is happening. Initial assessment. Perform an initial assessment of antenatal risk factors for fetal compromise at the onset of labor to determine whether intermittent auscultation or cardiotocography is offered as the initial method of fetal heart rate monitoring. Take into account the recommendations for fetal monitoring for women who are considered to be at higher risk of complications during labor because of existing medical conditions or obstetric complications, or for women with multiple pregnancies. Confirm with the woman which method of fetal monitoring has already been advised as part of their personalized care plan. Explain to the woman that risk assessment is a continual process, and the advised method of fetal heart rate monitoring may change throughout the course of labor. Explain to women that if there are no identified risk factors for fetal compromise, there is a risk of increased interventions with continuous CTG monitoring compared with intermittent auscultation, which may outweigh the benefits, and advice she is given by her midwife or obstetrician on the method of fetal heart rate monitoring will take into account the whole clinical picture. Intermittent auscultation. Offer women with a low risk of complications fetal heart rate monitoring with intermittent auscultation when in established first stage of labor. Do this as follows. Use either a Pinard stethoscope or Doppler ultrasound. Carry out intermittent auscultation immediately after a palpated contraction for at least 1 minute, repeated at least once every 15 minutes, and record it as a single rate on a partogram and in the woman's notes. Record accelerations and decelerations, if heard. Palpate and record on the partogram the maternal pulse hourly, or more often if there are any concerns, to ensure differentiation between the maternal and fetal heartbeats. If no fetal heartbeat is detected, offer urgent real-time ultrasound assessment to check fetal viability. Once the woman has signs of or is in confirmed second stage of labor, perform intermittent auscultation immediately after a palpated contraction for at least 1 minute, repeated at least once every 5 minutes, and recorded as a single rate on a partogram and in the woman's notes. Palpate the woman's pulse simultaneously to differentiate between the maternal and fetal heart rates. If there are concerns about differentiating between the two heart rates, seek help and consider changing the method of fetal heart rate monitoring. If, on intermittent auscultation, there is an increase in the fetal heart rate, as plotted on the partogram, of 20 beats a minute or more from the start of labor, or a deceleration is heard. Or carry out intermittent auscultation more frequently, for example, after 3 consecutive contractions. Or carry out a full review, taking into account the whole clinical picture including antenatal and existing or new intrapartum risk factors, maternal observations, contraction frequency, including hypertonus, and the progress of labor. If fetal heart rate concerns are confirmed, summon help. Or advise continuous CTG monitoring and explain to the woman and her birth companions why it is recommended and the implications for her choices of type and place of care. Transfer the woman from midwifery-led to obstetric-led care, providing that it is safe and appropriate to do so. Return to intermittent auscultation if continuous CTG monitoring has been started because of concerns arising from intermittent auscultation, but the CTG trace is normal after 20 minutes, unless the woman decides to remain on continuous CTG monitoring. Advise continuous CTG monitoring if fetal heart rate concerns arise with intermittent auscultation and are ongoing, or intrapartum maternal or fetal risk factors develop. Continuous cardiotocography. Do not use the advice in this guideline to categorize antenatal CTG traces. Use the advice in this guideline to interpret and categorize intrapartum CTG traces, but when interpreting how the baby is coping with labor, take into account maternal, fetal, and labor factors as well as CTG changes. Consider a lower threshold for escalation when there are any antenatal or intrapartum risk factors that could lead to fetal compromise. Encourage and help women to be as mobile as possible, to find positions that are comfortable for them, and to change position as often as they wish. Offer continuous CTG monitoring as part of fetal assessment if any antenatal or intrapartum risk factors for fetal compromise are present. See the section on indications for continuous cardiotocography monitoring in labor. Discuss with the woman and her birth companions the reasons for offering continuous CTG monitoring and explain that. A combination of antenatal risk factors, intrapartum risk factors, and continuous CTG monitoring are used to evaluate the baby's condition in labor. A continuous CTG monitoring is used to monitor the baby's heart rate and the labor contractions. It may restrict her mobility and the option to labor in water. A normal CTG trace indicates that the baby is coping well with labor. Changes to the baby's heart rate pattern during labor are common and do not necessarily cause concern. However, they may represent developing fetal compromise, so maintaining continuous CTG monitoring is advised if these occur. If the CTG trace changes or is not normal, there will be less certainty about the condition of the baby, and so maintaining continuous CTG monitoring is advised, in conjunction with a full assessment including checks for developing intrapartum risk factors, such as the presence of meconium, sepsis, and slow progress in labor. Our advice about her care during labor and birth will be based on an assessment of several factors, including her preferences, her condition, and the condition of her baby, as well as the findings from the CTG. Telemetry. Ensure wireless transducers are kept charged and maintained so that they are ready to use. Switch from wireless to wired transducers as soon as possible if there is signal loss which is not resolved by reducing the distance between the base unit and the woman in order to confirm whether or not there is a clinical problem. Indications for continuous cardiotocography monitoring in labor. Antenatal risk factors. Offer continuous cardiotocography monitoring to women in labor if it is in their personalized care plan. Offer continuous CTG monitoring for women in labor who have any of the following antenatal maternal risk factors: previous cesarean birth or other full-thickness uterine scar, or any hypertensive disorder needing medication, a prolonged ruptured membranes, but women who are already in established labor at 24 hours after their membranes ruptured do not need CTG unless there are other concerns, any vaginal blood loss other than a show, suspected chorioamnionitis or maternal sepsis, a pre-existing diabetes, type 1 or type 2, and gestational diabetes requiring medication. Offer continuous CTG monitoring for women in labor who have any of the following antenatal fetal risk factors: a non-cephalic presentation, including breech, transverse, oblique, and cord, including while a decision is made about mode of birth; a fetal growth restriction, estimated fetal weight below 3rd centile; a small for gestational age, estimated fetal weight below 10th centile, with other high-risk features such as abnormal Doppler scan results, reduced liquor volume, or reduced growth velocity; or advanced gestational age, more than 42 plus 0 weeks at the onset of established labor; or anhydramnios or polyhydramnios, or reduced fetal movements in the 24 hours before the onset of regular contractions. Consider continuous CTG monitoring if, based on clinical assessment and multidisciplinary review, there are concerns about other antenatal factors not listed above that may lead to fetal compromise. Ongoing risk assessment. Carry out a full assessment of the woman and her baby every hour. At each assessment include a maternal antenatal risk factors for fetal compromise, a fetal antenatal risk factors for fetal compromise, a new or developing intrapartum risk factors, a progress in labor including characteristics of contractions, frequency, strength, and duration, a fetal heart rate monitoring, including changes to the fetal heart rate pattern. Discuss with the woman any changes identified since the last review and the implications of these changes. Include birthing companions in these discussions if appropriate, and if that is what the woman wants. Obtain an in-person review of every hourly assessment by another clinician, fresh eyes, for women on CTG, to be completed before the next assessment takes place. Intrapartum risk factors. Be aware that intrapartum risk factors may increase the risk of fetal compromise, and that intrapartum risk factors that develop as labor progresses are particularly concerning. Offer continuous CTG monitoring for women who have or develop any of the following new intrapartum risk factors: contractions that last longer than 2 minutes, or 5 or more contractions in 10 minutes. The presence meconium. A maternal pyrexia, a temperature of 38 degrees centigrades or above on a single reading, or 37.5 degrees centigrades or above on 2 consecutive occasions 1 hour apart. Suspected chorioamnionitis or sepsis. A pain reported by the woman that appears, based on her description or her previous experience, to differ from the pain normally associated with contractions. A fresh vaginal bleeding that develops in labor. A bloodstained liquor not associated with vaginal examination that is likely to be uterine in origin and may indicate suspected antepartum hemorrhage. Maternal pulse over 120 beats a minute on 2 occasions 30 minutes apart. A severe hypertension, a single reading of either systolic blood pressure of 160 millimeters of mercury or more or diastolic blood pressure of 110 millimeters of mercury or more, measured between contractions. Hypertension, either systolic blood pressure of 140 millimeters of mercury or more or diastolic blood pressure of 90 millimeters of mercury or more on 2 consecutive readings taken 30 minutes apart, measured between contractions. Our reading of 2+ of protein on urinalysis and a single reading of either raised systolic blood pressure, 140 millimeters of mercury or more, or raised diastolic blood pressure, 90 millimeters of mercury or more. Confirmed delay in the first or second stage of labor. Or insertion of regional analgesia, for example, an epidural. A use of oxytocin. Consider continuous CTG monitoring if, based on clinical assessment and multidisciplinary review, there are concerns about other intrapartum factors not listed above that may lead to fetal compromise. Presence of meconium. When assessing risk at any time during labor, be aware that the presence of meconium can indicate possible fetal compromise, and may lead to complications, such as meconium aspiration syndrome. Consider the character of the meconium as part of the overall clinical assessment, in conjunction with other antenatal or intrapartum risk factors, and discuss the option of CTG monitoring with the woman. Recognize that the type of monitoring method used is the woman's choice, and support her decision. Be aware that meconium is more common post-term, but should still trigger a full risk assessment and discussion with the woman about the option of CTG monitoring. Use of cardiotocography for monitoring during labor. Review the previous fetal heart rate monitoring results, including any previous CTG traces, as part of the hourly risk assessment and in conjunction with other antenatal or intrapartum risk factors, and determine if there are any changes in baseline fetal heart rate, variability, or decelerations. If there are changes in the fetal heart rate pattern over time which indicate a change in the baby's condition, review antenatal or intrapartum risk factors for hypoxia. When reviewing a CTG trace, assess and document. Contractions. Baseline fetal heart rate. Variability. A presence or absence of decelerations and characteristics of decelerations if present. A presence of accelerations. If there is a stable baseline fetal heart rate between 110 and 160 beats a minute and normal variability, continue usual K as the risk of fetal acidosis is low. Differentiate between the maternal and fetal heartbeats hourly, or more often if there are any concerns. If there are concerns about whether the maternal heart rate is being heard rather than the fetal heart rate, discuss with the woman the methods available to differentiate and support her decision on which method to use. Options include a fetal heart rate auscultation with a Pinard stethoscope, bedside ultrasound scanning, continuous maternal heart rate monitoring using a pulse oximeter or the facility on the CTG equipment, a fetal heart rate detection using a fetal scalp electrode which is attached to the baby's head, but be aware this may detect maternal heart rate if there is no fetal heartbeat, so should always be used in conjunction with maternal heart rate monitoring. A simultaneous palpation of the woman's pulse while listening to the fetal heart rate. Be aware that it is particularly important to confirm the fetal heart rate in the second stage of labor, when it is easier to mistakenly auscultate maternal rather than fetal heart rate. If concerns about differentiation between the maternal and fetal heart rate remain, or if a fetal heart cannot be heard, obtain an urgent review by an obstetrician or senior midwife. Ensure that the CTG trace is of high quality and, if not, take action to improve the trace, for example, by repositioning the tocodynamometer, the transducer, or by using a fetal scalp electrode. When reviewing CTG traces, or evaluate changes on traces over time to ascertain changes in the baby's condition. Document any changes in the CTG trace from the previous review. Review the changes alongside any existing and new intrapartum risk factors. Think about the possible reasons for any changes, and take these and the whole clinical picture into account when planning ongoing care. Features of cardiotocography. Categorize the 4 features of the cardiotocography trace, contractions, baseline fetal heart rate, variability, decelerations, as white, amber, or red, indicating increasing levels of concern, and use alongside consideration of the presence of accelerations to classify the overall CTG trace. Contractions. Use a tocodynamometer to record contraction frequency and length on the CTG trace. Use the following to work out the categorization for contractions. See recommendation the 1st of April, 31 to work out the overall categorization for the CTG. White. Fewer than 5 contractions in 10 minutes. Amber. 5 or more contractions in 10 minutes, leading to reduced resting time between contractions. Or hypertonous. If decelerations are present, evaluate their timing related to contractions. If 5 or more contractions per 10 minutes are present, perform a full risk assessment. Take action to reduce contraction frequency as described in the section on underlying causes and conservative measures. I'll explain to the woman what is happening and ensure that she has adequate pain relief. Baseline fetal heart rate. Determine baseline fetal heart rate by looking at the mean fetal heart rate, excluding accelerations and decelerations, over a period of 10 minutes when the fetal heart rate is stable. When deciding if there is any change in baseline fetal heart rate, compare it with earlier CTG traces or recordings of fetal heart rate. Use the following to work out the categorization for baseline fetal heart rate. A white, stable baseline of 110 to 160 beats a minute. Amber, increase in baseline fetal heart rate of 20 beats a minute or more from the start of labor or since the last review an hour ago, or 100 to 109 beats a minute, or unable to determine baseline. A red, below 100 beats a minute, or above 160 beats a minute. When assessing baseline fetal heart rate, differentiate between fetal and maternal heartbeats and take the following into account. Baseline fetal heart rate will usually be between 110 and 160 beats a minute. Lower baseline fetal heart rates are expected with post-term pregnancies, with higher baseline rates in preterm pregnancies. A rise in baseline fetal heart rate may represent either developing infection or hypoxia. Although a baseline fetal heart rate between 100 and 109 beats a minute is an amber feature, continue usual care if this has been stable throughout labor and there is normal variability and no variable or late decelerations. Variability. Determine variability by looking at the minor oscillations in the fetal heart rate, which usually occur at 3 to 5 cycles a minute. Measure it by estimating the difference in beats per minute between the highest heart rate and the lowest heart rate in a 1-minute segment of the trace between contractions, excluding decelerations and accelerations. If there is an absence of variability, carry out a review of the whole clinical picture with a low threshold for expedited birth, as this is a very concerning feature. Use the following to work out the categorization for fetal heart rate variability. A white, 5 to 25 beats a minute. Amber, fewer than 5 beats a minute for between 30 and 50 minutes, or more than 25 beats a minute for up to 10 minutes. A red, fewer than 5 beats a minute for more than 50 minutes, or more than 25 beats a minute for more than 10 minutes, or sinusoidal. Take the following into account when assessing fetal heart rate variability. A variability will usually be between 5 and 25 beats a minute. Intermittent periods of reduced variability are normal, especially during periods of quiescence, sleep. Certain medicines, such as opioids, may lead to a reduction in variability, but all other intrapartum risk factors should be carefully reviewed as a potential cause. For example, look for other features on the CTG such as a rise in the baseline fetal heart suggestive of another reason such as sepsis. Increased variability refers to oscillations around the baseline fetal heart rate of more than 25 beats a minute, and shorter episodes lasting a few minutes may represent worsening fetal condition. Obtain an urgent review by an obstetrician or senior midwife and consider expediting birth if there is an isolated reduction in variability to fewer than 5 beats per minute for more than 30 minutes when combined with antenatal or intrapartum risk factors, as this is associated with an increased risk of adverse neonatal outcomes, or there is a reduction in variability to fewer than 5 beats per minute combined with other CTG changes, particularly a rise in the baseline fetal heart rate, as this is a strong indicator for fetal compromise. Decelerations. Define decelerations as transient episodes when the fetal heart rate slows to below the baseline level by more than 15 beats a minute, with each episode lasting 15 seconds or more. An exception to this is that in a trace with reduced variability, decelerations may be shallow. When assessing the significance of decelerations in fetal heart rate, consider their timing, early, variable, or late, in relation to the peaks and duration of the contractions. The duration of the individual decelerations. Whether or not the fetal heart rate returns to the baseline heart rate. How long they have been present for. Whether they occur with over 50% of contractions defined as repetitive. The presence or absence of shouldering. The variability within the deceleration. Regard the following as concerning characteristics of variable decelerations. Lasting more than 60 seconds. A reduced variability within the deceleration. A failure or slow return to baseline fetal heart rate. A loss of previously present shouldering. Describe decelerations as early, variable, or late. Do not use the terms typical and atypical, as they can cause confusion. Use the following to work out the categorization for decelerations in fetal heart rate. A white, no decelerations, or early decelerations, or variable decelerations that are not evolving to have concerning characteristics. Amber, repetitive variable decelerations with any concerning characteristics for less than 30 minutes, or non-repetitive variable decelerations with any concerning characteristics for more than 30 minutes. A red, repetitive variable decelerations with any concerning characteristics for more than 30 minutes, or late decelerations, or acute bradycardia, or a single prolonged deceleration lasting 3 minutes or more. Take into account that the longer and later the individual decelerations, the higher the risk of fetal compromise, particularly if the decelerations are accompanied by a rise in the baseline, a tachycardia, or reduced or increased variability. Start conservative measures and carry out an urgent obstetric review if there are decelerations lasting longer than 30 minutes in the presence of either a rise in the baseline heart rate or reduced variability. Take into account antenatal and intrapartum risk factors, such as suspected sepsis, the presence of meconium, slow progress of labor, or the use of oxytocin, to determine whether there is a need for expedited birth. If variable decelerations persist and other CTG changes are present, obtain an urgent review by an obstetrician and a senior midwife, as there is a risk of fetal compromise and acidosis. If variable decelerations with no concerning characteristics and no other CTG changes, including no rise in the baseline fetal heart rate, are observed, be aware that these are very common, can be a normal feature in an otherwise uncomplicated labor and birth, and are usually a result of cord compression. Support the woman to change position or mobilize. Take the following into account when categorizing early decelerations. They are uncommon, benign, and usually associated with head compression. They are not accompanied by any other CTG changes, such as reduced variability or a rise in the baseline fetal heart rate. Accelerations. Define accelerations as transient increases in fetal heart rate of 15 beats a minute or more, lasting 15 seconds or more. Take the following into account when assessing accelerations in fetal heart rate. The presence of fetal heart rate accelerations, even with reduced variability, is generally a sign that the baby is healthy. The absence of accelerations on an otherwise normal CTG trace does not indicate fetal acidosis. Categorization of cardiotocography traces, all stages of labor. Include CTG categorization as part of the full assessment of the condition of the woman and baby. Be aware categorization is a tool which quickly communicates the current state of the CTG and should be used together with antenatal and intrapartum risk factors to assess changes over time. Categorize CTG traces as follows, based on whether each of the four features, contractions, baseline, variability, decelerations, have been scored as white, amber, or red. Normal. No amber or red features, all four features are white. Suspicious. Any one feature is amber. Pathological. Any one feature is red, or two or more features are amber. Take into account any change in the categorization of the CTG alongside other antenatal and intrapartum risk factors for hypoxia. Discuss the change and its implications with the woman, and take into account her preferences when deciding how to proceed. Special considerations for cardiotocography traces in the second stage of labor. Take into account that interpretation of CTG traces in the second stage of labor is more challenging than in the first stage of labor. Have a lower threshold for seeking a second opinion or assistance. Ensure the fetal heart rate is differentiated from the maternal heart rate at least once every 5 minutes. Consider monitoring the baby with a fetal scalp electrode if there is concern about confusing the heart rates, but if this cannot be achieved, expedite birth. In the second stage of labor, if fetal heart rate accelerations are recorded, be aware that these are most likely to be maternal pulse. If fetal heart rate decelerations are recorded, look for other signs of hypoxia, for example, a rise in the baseline fetal heart rate or a reduction in variability. Take into account that onset of hypoxia is both more common and more rapid in the active second stage of labor. Take an increase in the baseline fetal heart rate of 20 beats a minute or more from the start of labor or since the last review an hour ago as a red feature in active second stage labor. If CTG concerns arise in the active second stage of labor, obtain an obstetric review. Consider discouraging pushing and stopping any oxytocin infusion to allow the baby to recover, unless birth is imminent. Agree and document a clear plan with time limits for the next review. For a short explanation of why the committee made these recommendations and how they might affect practice, see the rationale and impact section on use of cardiotocography for monitoring during labor. Making care decisions based on the cardiotocography trace. Assess fetal well-being every hour, taking into account antenatal and intrapartum risk factors in conjunction with interpretation of the CTG trace. Take the whole clinical picture into account when making decisions on how to manage the labor, including maternal observations, contraction frequency, and labor progress. Discuss with the woman and her birth companions what is happening, taking into account her individual circumstances and preferences, and support her decisions. If the CTG trace is categorized as normal, continue CTG unless it was started because of concerns arising from intermittent auscultation and there are no ongoing antenatal or intrapartum risk factors and usual care. Continue to perform a full risk assessment at least hourly and document the findings. If the CTG trace is categorized as suspicious and there are no other concerning risk factors, perform a full risk assessment, including a full set of maternal observations, taking into account the whole clinical picture, and document the findings. Note that if accelerations are present, then fetal acidosis is unlikely. If the CTG trace was previously normal, consider possible underlying reasons for the change. Undertake conservative measures as indicated. If the CTG trace is categorized as suspicious and there are additional intrapartum risk factors such as slow progress, sepsis, or meconium, Perform a full risk assessment, including a full set of maternal observations, taking into account the whole clinical picture, and document the findings. Consider possible underlying causes and undertake conservative measures as indicated. Obtain an urgent review by an obstetrician or a senior midwife. Consider fetal scalp stimulation or expediting birth. If the CTG trace is categorized as pathological, obtain an urgent review by an obstetrician and a senior midwife. Exclude acute events, for example, cord prolapse, suspected placental abruption, or suspected uterine rupture that need immediate intervention. Perform a full risk assessment, including a full set of maternal observations, taking into account the whole clinical picture, and document the findings. Consider possible underlying causes and undertake conservative measures as indicated. If the CTG trace is still pathological after implementing conservative measures, obtain a further urgent review by an obstetrician and a senior midwife. Evaluate the whole clinical picture and consider expediting birth. If there are evolving intrapartum risk factors for fetal compromise, have a very low threshold for expediting birth. If there is an acute bradycardia or a single prolonged deceleration for 3 minutes or more, urgently seek obstetric review. If there has been an acute event, for example, cord prolapse, suspected placental abruption, or suspected uterine rupture, expedite the birth. Consider possible underlying causes and undertake conservative measures as indicated. Make preparations for an urgent birth, including a request for pediatric or neonatal support. Expedite the birth if the acute bradycardia persists for 9 minutes, or less if there are significant antenatal or intrapartum risk factors for fetal compromise. If the fetal heart rate recovers at any time up to 9 minutes, reassess any decision to expedite the birth, but take into account other antenatal and intrapartum risk factors and discuss this with the woman. If a decision is made to expedite birth, ensure the time at which urgent review was sought and the time the decision was made are documented. Underlying causes and conservative measures. If there are any concerns about the baby's well-being, be aware of the possible underlying causes and start one or more of the following conservative measures based on an assessment of the most likely causes. A maternal position, as this can affect uterine blood flow and cord compression, encourage the woman to mobilize or adopt an alternative position and to avoid being supine. Hypertension. Do not offer intravenous fluids to treat fetal heart rate abnormalities unless the woman is hypotensive or has signs of sepsis. If the woman is hypotensive secondary to an epidural top-up, start intravenous fluids, move her to a left lateral position, and call an anesthetist to review. Excessive contraction frequency. Reduce contraction frequency by reducing or stopping oxytocin if it is being used. Offer a tocolytic drug. A suggested regimen is subcutaneous to butylene 0.25 milligrams. Do not offer maternal facial oxygen therapy as part of conservative measures because it may harm the baby. However, it can be used if it is given for maternal issues such as hypoxia, or as part of pre-oxygenation before a potential anesthetic. Do not offer amnioinfusion for intrauterine fetal resuscitation. Fetal scalp stimulation. If the CTG trace is suspicious with antenatal or intrapartum risk factors for fetal compromise, then consider digital fetal scalp stimulation. If this leads to an acceleration in fetal heart rate and a sustained improvement in the CTG trace, continue to monitor the fetal heart rate and clinical picture. Be aware that the absence of an acceleration in response to fetal scalp stimulation is a worrying sign that fetal compromise may be present and that expedited birth may be necessary. Fetal blood sampling. NICE is unable to make a recommendation about fetal blood sampling because of limited evidence. Record keeping for cardiotocography. To ensure accurate record keeping for CTG, make sure that date and time clocks on the cardiotocograph monitor are set correctly. Ensure the recording or paper speed is set at 1 centimeter a minute and that adequate paper is available. Label traces with the woman's name, date of birth, hospital number or NHS number and pulse at the start of monitoring and the date of the CTG. Individual units should develop a system for recording relevant intrapartum events, for example, vaginal examination and sighting of an epidural in standard notes and or on the cardiotocograph trace. Keep cardiotocograph traces for 25 years and, if possible, store them electronically. In cases where there is concern that the baby may have sustained a possible brain injury, photocopy cardiotocograph traces, if they are not available electronically, and store them indefinitely in case of possible adverse outcomes. Ensure that tracer systems are available for all cardiotocograph traces if stored separately from the woman's records. Develop tracer systems to ensure that cardiotocograph traces removed for any purpose, such as risk management or for teaching purposes, can always be located. Terms used in this guideline: early decelerations. Repetitive and periodic slowing of the fetal heart rate with onset early in the contraction and return to baseline at the end of the contraction. These are uncommon. Hypertonus, a contraction lasting 2 minutes or longer. Late decelerations, slowing of the fetal heart rate with onset mid to end of the contraction and the lowest point more than 20 seconds after the peak of the contraction and ending after the contraction. Variable decelerations. Intermittent and periodic slowing of the fetal heart rate with a variable time in relation to the contraction.